Good afternoon and welcome to the Greenway and Health iPASS webinar. Thank you for joining us today. My name's Courtney Ward and I'm one of the marketing managers here at Greenway. I'm joined today by Raj Raju, founder and group president of Health iPASS, Kaylee Smith, pre-cert coordinator of Carrollton Orthopedic Clinic, and Ben Butler, CEO of Carrollton Orthopedic Clinic. Before I pass it over to Raj, I'd like to go over a few items to ensure you have a positive experience. Firstly, your CEU credit will come from Health iPASS within 72 hours, so please be on the lookout for that. Next, this presentation is being recorded, and this recording and presentation will be available via My Greenway once this is concluded. You can find a copy of the presentation slides in the resources section of your On24 console. Feel free to play around with the dashboard and move things around. And if you'd prefer to listen to the presentation via phone, you can do so by logging in via the join link on your phone, and it'll allow you to experience the same presentation just on a different device. If you happen to experience any audio or connectivity issues, please press F5, that's F5, or refresh your screen. Lastly, we highly encourage that you submit any questions that you may have by using the Q&A tool, which we will address at the end of this presentation. Now take it away, Raj.
Thank you, Courtney, and good afternoon, everyone. First of all, belated happy Valentine's Day. Hope all of you guys had a terrific Valentine's Day yesterday. I'm Raj. I'm the founder and group president of Health iPASS. I come from a large family of physicians, and that was kind of the genesis of why I started Health iPASS. We are a proud member of the Greenway marketplace. We have clients like Carrollton Orthopedic on both Intergy as well as the Prime Suite platform. And very, very warm welcome to all of you guys that dialed in to listen to Ben and Kaylee share their wisdom and their journey in terms of best practices that they have employed in overcoming the challenges that we all face in the backdrop of what's going on right now. To just quickly introduce the speakers and our guests here, Ben Butler is the CEO of Carrollton Orthopedic Clinic. This is his 11th year as the CEO of Carrollton, and that's about 40 miles kind of west of Atlanta. Ben started his career in healthcare at Piedmont Hospital and now has spent over 18 years of experience both in hospital and practice administration. He's an industrial engineer by background from Georgia Tech and did his MBA from Duke. And very, very pleased to have you on the call today, Ben. Thank you for joining. Kaylee Smith has been with Carrollton Ortho for about 8 years. She oversees billing and accounting, and if that's not adventurous enough, she also leads all of their pre-certification process. And as we know, with the payers of today, there's a lot of stuff going on inside the pre-cert bucket. So it'll be great to hear from Kaylee with respect to both of those areas that she kind of oversees. I mentioned briefly about Carrollton, but I think who else can speak better than both Ben and Kaylee? So if you could, Ben, share with the audience a little bit more about Carrollton Orthopedic, please.
Sure, yeah, thanks, Raj. Hello, everybody. Carrollton Ortho, as we are affectionately called here locally. We're a medium-sized orthopedic and spine practice located about 30 miles west of Atlanta. We've been around since 1977, as you see on the graphic there. We've got 13 ortho, spine, and pain management providers, and then another 10 to 12 mid-level providers on top of that. We are your typical orthopedic, private, independently owned practice. We've got 4 locations, a surgery center, MRI, CT, physical therapy, just a very typical ortho practice. So we do about 100,000 office visits a year and a little over 4,000 surgeries each year. So a very busy group that faces all the challenges challenges and headaches that similar to many of you that are on the call today. So we have been on Greenway Prime Suite since 2012, and many of you may recognize our city of Carrollton. So that's where Greenway's original headquarters was located, and I think they've still got several business units here. But so many of you may have visited Carrollton for training or other educational sessions over the last few years. So with that said, Raj, you ready to jump on in?
Thank you, Ben. And just to kind of set the stage for what we're going to cover, we're going to go through kind of broad challenges that face all healthcare providers to just kind of set the broad context. And before we go into the 10 best practices right after, we're going to do a small poll that you'll see pop up on your screen, and you can select what best describes, what the challenges are for your practice. And that'll help Ben and Kaylee and myself to make sure that we are fine-tuning based on, the feedback that we get. So without further ado, let me just kind of jump into the first challenge. And this is really about reimbursement from payers, right? As we look at what's happening in the medical practice world and in healthcare, this is a snapshot over the last 20 years as to what has happened to Medicare and reimbursements from Medicare. On one side, you see consumer price has, from an inflation standpoint, has gone up over 40% over these 2 decades. You see inpatient hospital reimbursement as well as outpatient hospital reimbursement have grown above and beyond the consumer price. Practice costs, just like the consumer price, have gone up. And yet, if you look at physician reimbursement, it has remained relatively flat. And in fact, if you adjust for inflation, you can say there was a 22% drop in physician reimbursement from Medicare. And as the going says, whichever direction Medicare goes, so go most of the commercial payers. And an interesting anecdote, I was talking to my uncle, who was a urologist for over 50 years in Ohio. And he still reminisces about the days when there was no such thing as an allowable, and the charge master that they had effectively is the reimbursement that they received. Obviously, that's gone way off in terms of what the current reality is. And just looking at Medicare for this past year of 2022, there were roughly 3 different cuts. There was a 2% sequestration adjustment. There was a PAYGO adjustment for about -4%. And then just from a budget neutrality standpoint and a physician update standpoint, roughly about a 10% cut in Medicare. And I was curious, Ben, if you could comment on this shift of reimbursement, if you will, from the payers and what you guys have seen over the years in terms of your experience at both Piedmont as well as Carrollton Ortho.
It's a pretty stunning chart when you see it, all this information together. In our world, we all think that we have faced the same challenges and when it comes to reimbursement, but this pretty clearly lays out the more significant impact to the physician practice as opposed to hospitals and both inpatient and outpatient. So this is definitely consistent with what we've seen. It's ironically, I was doing some price analysis on cash pay for our MRIs recently, and found that we are actually charging the exact same thing cash price for an MRI today that we were 7 years ago. So that just kind of shows you validates some of this information here, and just tells you the weird healthcare environment that we live in. I was actually relieved that it wasn't 25 to 30% less than it was 7 years ago. But as payers has shifted to high deductible health plans, we have certainly felt that impact. So this is definitely consistent with what we see.
Yeah, and speaking of high deductible health plans, in 2021, the high deductible health plans for all those that are commercially insured have effectively become the majority. The scale has tipped over to over 50%, almost 56% of the US employees with an employer-sponsored health plan have become high deductible. So obviously putting more of a premium in terms of how we deal with the consumer of today, their expectations around price transparency, their expectations around the type of engagement that they're looking for, and the fact that they're now responsible for a larger portion of the bill. And as we looked at data across our own clients across a very broad, both geographic as well as specialty spectrum, what we see is this definite shift of plan design, not just towards high deductible health plans, but also increasingly towards high deductible health plans that don't have a copay. And that means 100% of what we potentially get paid as a medical practice is going to come from patient out of pocket. And I was curious, Ben, if you could add to this commentary in terms of what you guys are seeing at Carrollton Ortho and how your patient base itself has kind of shifted towards high deductible health plans.
Yeah, really, you can look no further than your own company, your own practice on this one. As an employer, we moved to a high deductible plan several years ago, trying to help defray that ongoing, ever increasing cost of employer sponsored insurance. And so obviously that's consistent with the rest of the companies in our area and most of the companies in your area. So the first quarter is also, it's especially challenging time for most of us to, from a daily cash on hand standpoint, because, all these deductibles reset. And we definitely see more patients going on payment plans this time of year than we do as the year goes on. So much more stress on the medical practice in these first few months than once these deductibles get hit, it becomes a little bit easier.
Yeah. Thank you for that, Ben. And obviously, Kaylee, that impacts the pre-cert process also, especially when more people have these high deductible health plans, correct?
It does, and it definitely helps with iPASS having the cost estimator we've implemented, using that with the payment plan to help patients with the high deductibles, especially the 3,500 and up, set them up on the payment plan going forward, because we do most of our procedures in-house, surgeries, MRIs, things of that nature. That way they have a heads up going forward. They know what they're going to pay.
Yeah. And of course, we'll expand on that in terms of the best practices, in terms of what you guys are doing, Kaylee. So, the third big topic that I want to kind of bring up is the regulatory framework that all of us face as a medical practice, specifically the No Surprises Act and the mandate of what the NSA compliance means to each individual practice, how it affects a medical practice. What do we have to do today for pure self-pay patients that don't have an insurance, if you will, as well as, where the writing is on the wall. Ben, and I'll come to you also, Kaylee. When you guys first kind of heard about the No Surprises Act, what was your reaction? What was the talk track internally in terms of how do we best comply with the NSA for you guys?
For us, I've felt like we were always good at giving patients an estimate on what their gross charges may be. That was an easy task for all of us. But the reality of that is we had very little idea of what their true out-of-pocket cost was going to be. We were confident in sharing the gross price, and so no surprises really. Kind of like most of you guys, it put us on the spot to be able to give them a better idea, with 100 to 200 different types of insurance plans that we accept, and trying to, get as close as possible. So I know Kaylee can kind of speak a little bit more to our experience with No Surprise.
Yeah, so when they implemented that fully back in the beginning of 2022, we had to figure out a way with our out-of-network self-pay patients how we were going to best meet their needs. So we went live July 2022 with iPASS. The self-pay patients, automatically we knew the estimator in iPASS would be the way to go. It automatically, you plug in what type of service, the codes they're going to have. You can print that out, email it. It's the way to go. We can automatically pretty much give them the cost of their service that day, what they're having done. Of course, service change, things like that. We can plug that in on the back end, but front end, if it's just a visit, x-rays, things like that, we can give that to them time of service.
Yeah, so in other words, NSA mandate both today in terms of self-pay as well as where it's probably headed in terms of making it a requirement for all patients, insured or not insured. You knew you needed a better set of tools in terms of how to best comply with NSA, right, Kaylee?
Yes, legislation is headed to make it for all insured and uninsured patients.
Right. And, just the fourth big issue that, of course, we see across our client base and certainly across the industry is the staffing conundrum, the great resignation, whatever phrase you want to use. It's become very real for practices. It's affected most practices. In fact, 3 out of 4 practices talk about having to make changes due to the staffing shortages that they've experienced. And sometimes that's on the clinical side. It's also on the administrative side. And in fact, this slide was very telling in terms of looking at where medical practices have the largest vacancies. It tends to be kind of the front-end registrars, it's the PSRs, it's the billing specialists, people that are doing follow-ups, people that are doing denials, billing and coding. And these are all incredibly important roles, both to make sure the patient feels welcome and also to make sure that we've got the right level of training done. Very hard to obviously get somebody trained. And I was just curious, both from Carrollton Ortho standpoint, Ben, as well as what you hear from your peers in the industry, how acute is it, and what are you guys? How do you guys kind of think about staff shortages that you're facing at this point?
Well, these 3 slides that you just went through, that really should surprise nobody on this call. The challenges within healthcare staffing environment have become significant these last 3 years, whether it's the hourly wage you pay or how big your non-clinical staffs are getting. It's just so different now. I can remember probably 6-7 years ago, we had one person handling all prior authorizations for our clinic, a busy medical clinic, and now we've got 5 that do pre-certs, prior auths, and we could probably use 2 more. So it's just where does it stop? But the takeaway really for me, when you look at this list right here, the most critical roles, you see some of the most critical roles in the practice listed here from an efficiency standpoint. If you want to have a good, efficient practice with a good AR and other sound billing practices, you better have a strong front desk, strong schedulers, authorization staff, and some others on this list. And, we ask a lot of these roles listed here. The reality is a lot of these roles listed are on the lower end of the pay scale. So we are asking a lot of the employees in the office that are on the lower end of the pay scale. Yeah,
no, for sure. And I think that may be a good segue, right? We heard about 4 broad things. Reimbursement from payers is declining. It's going more and more towards patient out-of-pocket. There is a new set of regulatory framework, including the No Surprises Act, that creates new pressure points for all medical practices. And on top of all of that, we're dealing with this great resignation and staffing shortage that you're seeing. And before we jump into kind of the best practices, I wanted to pull up this brief poll here. It's going to ask you the question in terms of what are your biggest initiatives or challenges as you look at the new year. And I think if I'm doing this right, I'm supposed to advance. There you go. And I'll give each of you guys just a quick couple of seconds to respond, if you could, please. And we'll use that to guide the conversation in terms of what parts are most important for you. And you can certainly pick more than one item in terms of what's most important for you guys. Okay, we'll do 3, 2, and 1. Let's go see what the group thinks. So not surprisingly, Ben, 42% talk about staffing challenges and how to address whether it's technology or something else, as you'll cover during best practices in terms of how to address the staffing challenges. Patient payments, whether it's before people come in clinic, at check-in, at checkout, for surgeries, for all post-visit, certainly seems to be a big item. And billing and cost estimation and patient check-in seem to be clustered as kind of the next of the top 3 items. So as you and Kaylee kind of talk about the best practices, it would be great to have you guys take this into account in terms of the things that you want to sort of highlight. So let's go shift gears and go to the second part of this presentation. And accountability, Ben, not surprisingly, you said is best practice number 1. I would love for you to maybe just expand on what you mean by accountability and what you guys specifically are doing inside Carrollton Ortho.
Sure. You really need a system that's going to allow you to measure how productive your business staff is, how efficient is that front desk, those front desk personnel, who's the best at collecting copays, who collects well off old balances, who's the most efficient with check-in. So you definitely want to have a system to where you can track and use that information to make the group better. There's no question. So we've got a current situation where we've got 4 people that work our front desk at our main location, and probably have 2, maybe 3 of them that check in probably 95% of the patients. So we're in the process now of using really some of those reporting features to, within Health iPASS to kind of help set some clear performance goals with all 4 for this group to help better balance out those numbers. I'm sure many of you see similar things in your offices where 2 or 3 kind of pull the weight of the majority of the group.
Yeah, thank you, Ben. And obviously, this is looking at external benchmarks in terms of net collection rates, not just the front desk part of the collections. And kind of going into this idea of patient as a payer, you mentioned financial policy becomes even more important, right? And we see practices that may not have revised it in many years. How do you guys, how have you addressed the revisions to financial policy, and what specifically are you guys doing with respect to your patient financial policy?
I think you've got to set clear expectations up front, right? You've got, a lot of times, our patients are, these consumers, they're going to Target, they're going to Walmart. They know when they leave that store with a product, they're going to have to pay for it. And they know exactly how much it's going to cost because that store sets a clear idea of what it costs and how you can leave with that item. So, our world is obviously a little bit different, but if we do that good job of setting expectations up front, communicating the potential cost of the visit that day, the surgery, the MRI, whatever it may be, it's going to make life a little bit easier for you when you're collecting those balances. If the patient is thinking that, the MRI is going to cost them, about $200 or $300 out of pocket, and then all of a sudden they get a bill for $1,200. Well, most of you know the challenges that's going to create. So many of you have a card on file policy. We're big fans of that. We're big fans of card on file. We don't require it, but we definitely offer and promote that as a policy within the office.
Yeah, thank you for that, Ben. And scheduling, right, you said is number 3. I was just looking at a report yesterday, maybe not surprising, but as high as 76% of the patients, average consumer population, said they want to be able to get on somebody's schedule at their convenience, so to speak, right? And scheduling, of course, is top of the funnel. I was curious if you could comment on scheduling improvements and how you guys have adapted your scheduling process, both for the technology that you're using, as well as in general, just what improvements you guys have brought to scheduling.
So online scheduling, like you said, that's a request that we get every day. We have not rolled that out to our patients yet, but that's something that we definitely want to do. I think about a real life example. I've got a 3-year-old son, and we dread haircuts, right? We can't, taking a 3-year-old to get his haircut. So mainly because you take him to that barbershop, you don't know how long the wait's going to be. He's going to have to sit still while he's getting his haircut. Well, so recently we've got a local place that we love, and but we didn't like going there because you didn't know if you were going to be there for 15 minutes or an hour and a half, and it was just the unpredictable nature of the visit. But I think it was a holiday weekend. My wife got online, saw that this place books online appointments. She books an appointment. We go in. We're in and out within 15 minutes, and it was a satisfying experience. And it was at a place that we weren't going to go. We were simply not going to go. But because of the ease of scheduling, that's why we took him there. And so there are lessons in that, obviously, for medical practices, and we've all got to take advantage of that.
And from the current process, has something changed in terms of the data that you collect during scheduling with a call center assisted or scheduling team assisted scheduling process today, Ben?
We try to collect as much as we can on the front end. We probably get close to 1,000 calls into our office every day. So you can imagine that's a huge burden on those schedulers, those phone operators. But we try to what we want to do is we want to get as much done prior to them walking in the door as we possibly can. And so one way we do that is send them a text or an email and have them fill out all of their new intake paperwork electronically before they arrive. We've been, we like everybody else thought, our patients will never do that. Our patients are older. We've heavy Medicare population, but we've definitely seen that's, we probably have a better rate of success with the older population completing it prior to the visit than maybe some of the younger population. So.
Yeah, some of us like to follow any prescribed, steps that a medical practice or a doctor say. And not surprising at all. Across many orthopedic groups and many even geriatric kind of practices, urology practices, and so on, we see an interesting adoption rate trend in terms of people that, that are elderly, right? Folks that are 65 and over. It's actually quite surprising. And I think we have Apple and Steve Jobs and all the things that Google and Android have done to make smartphones so friendly and easy to use that it certainly has become mobile first in terms of how we think about the user experience. And it's really bearing out, as you said, Ben, in terms of how we get a high degree of compliance from a pre-arrival check-in, pre-arrival payment standpoint. in that segment of the population. Just a very quick reminder for those of you that are on the phone, this is your opportunity to type in your questions. Can't promise we'll get to all of them, but we'll try to get to many of them as much as possible during this session. I also saw a handful of questions pop up as we were talking about where someone was interested in the specifics of how Health iPASS works with Prime Suite and Health iPASS works with Intergene. I would ask respectfully that we maybe set up a separate session one-on-one with those of you that need that, and we'll be happy to share the details of the integration. It'll hopefully become obvious as Ben and Kaylee kind of talk about the different tool set that they're using in Health iPASS in terms of the depth of the integration and the capabilities of the integration with, in their case, Prime Suite, but same thing exists for Intergene as well. You touched on this before, and I'm going to ask Ben and also you, Kaylee, to talk about this time of service excellence. What has changed for you guys over the past few years, both with Health iPASS and even prior with another tool that you were using before, Ben, in terms of time of service from a revenue cycle standpoint?
You know, unfortunately, one of the things that we have to do at the time of service is ask for money. And a lot of times that can be difficult depending on who the employee is that's there. But our staff does a really good job of doing that. I think with incorporating that with Health iPASS, who was able to ask for that, you know, electronically prior to the visit. You know, I've always been amazed that people are, you know, the patients are much more likely to pay when it's their phone or their PC or iPad telling them what they owe than it is the live front desk person. And also just kind of takes that confrontational type moment out of it. So it's crazy to me, but, you know, I think a lot of you would agree that, you know, the patients have just gotten different over the last 3 years. We've seen more aggressive behavior and just, you know, I hate to say it, but just a general overall just rudeness and kind of different demeanor coming from patients. And so, you know, our staff does a good job of trying to be human. You know, a pretty simple mantra, but very powerful for us to, you know, to try and play more of a compassionate role with our patients. But yeah, that's the great thing to me about the integration with Greenway and Health iPASS, in the sense that it knows, you know, it knows what the copay is based on the insurance. It knows what deductible has been met. And it presents that information to the patient in a very clean and user-friendly format.
Yeah, and I saw the stats from your group in terms of the almost 100% in terms of copay conversion, which is a phenomenal thing, Ben and Kaylee. And also a very high degree of conversion of, to your point, with the integration and it pulling the exact balance that the patient owes Carrollton Orthopedic and presenting it and allowing them in one click to kind of seeing the detail. It's amazing that you can achieve a higher degree of conversion on prior balances as opposed to a human asking for money, you know, with 5 other people, 10 other people, 20 other people in the waiting room. It's quite remarkable to us to see that conversion, and the human psyche, as you said, right, has changed. We are a lot more, we kind of believe, you know, what the system is telling us. And obviously it reflects the exact real-time sort of balance. I was going to ask Kaylee, in your work from a pre-cert standpoint, Kaylee, for any of patients that are on HMOs, patients that have a office procedure, how do you guys think about collection at time of service for any kind of deposits, or are you kind of trying to do that pre-service, Kaylee?
So we are starting to implement, since we have joined iPASS with the cost estimator of implementing. If it is above a certain amount, they will receive the cost estimator via email. We have a text system to let them know the total cost and the payment options, how they want to break it up over 2, 3, 4 months, the amounts they can pay on that, or they can pay it in full at time of service. And also at pre-service check-in, of course, it shows them the prior balance. The way iPASS integrates with Greenway, it breaks down, like you said, each service. So I feel like it's cut down on billing costs slightly because they can see line by line, hey, this was an office visit. This wasn't actually surgery. It was an injection, where we had kind of confused patients before. They didn't know what their balance was for. And we're actually seeing an uptick in revenue from that, I believe.
Yeah, and just to address, thank you for that, Kaylee, the questions that some of the folks were asking about the specifics of the integration. For you guys, whatever money gets collected, whether it's prior balance, whether it's copay, whether it's a deposit, those things automatically post back into Greenway, correct? And can you just expand on that in terms of how it posts into Greenway?
So ours automatically posts. The balances will automatically apply to balances. Deposits will post as a prepay credit. And once the service is performed, we can go in and then manually move the money to the service that was performed. But any balances will post to the balance automatically with no one physically having to go touch anything needed.
Yeah, great. Thank you for that. Kaylee, we'll move to, I guess, item number 5. And this is, we've been talking about price transparency and cost estimates. And Kaylee, you've been very, very close to this. Do you mind just talking through what you guys have done in terms of price transparency? And then I'll ask Ben to add any other commentary that he may want to add to it. But we'll start with you, Kaylee.
So for the price transparency, we've been offering, once service is set up, patient comes in, we know what they're having done, the cost estimator, we utilize that, can print that, like I said, text that, email it, they have a copy of it, what services will be performed, they have the estimate in hand, they can either choose to have the service pay for it, set up payment plan, or, hey, I want to wait on this, I don't have this kind of money, or let me wait a minute and shop around. And usually they find we are one of the more competitive price people in the area. And they wind up calling, hey, I couldn't find anyone cheaper. Let me set my payment plan up. I want to get on your MRI schedule, or I want to get my epidural set up, or I want to come back in and have my appointment.
Yeah, that's interesting. I mean, you're basically saying your price as an independent medical practice compared to the big system and the big box players could indeed be a competitive advantage as patients become more savvy with more deductibles, more out of pocket, and they're kind of shopping, if you will, and this could very well be a competitive advantage to your practice.
Definitely
is.
As it relates to competitive advantage, certainly against the hospital for several things, from an imaging standpoint, from an outpatient surgery standpoint. Obviously hospitals are much more expensive. We use that to our advantage. We've also seen with so many groups becoming hospital owned, we see that as well. Competing against other physician practices, and so we've definitely seen that as an advantage. You mentioned it. I mean, this is the direction that it's going. I mean, we've got to embrace the challenge of making sure the consumer, making sure the patient knows exactly how much something is going to cost in your practice. Certainly within a margin of error, but they know, right now they know exactly what something costs, where they can get it cheaper, and most likely where they can go and have the best experience possible. So that's healthcare now. The EMR, the EMR doesn't matter really which EMR you're on. The EMR does a great job at collecting that information and hosting that information. But, a lot of times the EMR can be, deficient at being able to pull the information on a per patient, per visit basis. And you really need an additional tool, something that sits on top of that EMR to really help you extract that information out of the EMR. And so that's one good thing that that Health iPASS does is we've seen it in the comments, some of the questions. It integrates very well with Prime Suite, and yeah, there's no issue there from an integration standpoint for sure.
Yeah, and we'll expand on that. This is, by the way, available for both Prime Suite, and with some of the recent enhancements and work that has been done as part of our integration with Intergy. Now we are on parity with all the things that Ben and Kaylee have been talking about, as far as Intergy as well. So obviously we'll address that as in the individual conversations. I'm going to go to the sixth topic, and this is sometimes controversial, Ben, for people that haven't embraced this notion of card on file. They find that it may scare patients away. It, is it required for all patients? Is it optional? And how to strike the right balance in terms of a card on file or payment assurance program. Can you just maybe elaborate a little bit, Ben, and anything, Kaylee, you want to add afterwards, in terms of how you have thought about card on file, and what have you found in terms of how your patients have embraced, and any best practices, any tips that you can share, Ben, in terms of card on file usage at Carrollton Ortho?
The more auto pay that you have set up, the better. I think we would all agree with that. But we do have a card on file program. We don't require it with patients. We do try to require it with payment plans. If you want to be on a payment plan, we do require for you to put your card on file. It's been very successful. Typically what we've seen is it's more successful with probably the under 55 crowd than it is 55 and up. That should be consistent with what you would expect. But we want to make it as easy as possible for patients. And so if a patient doesn't have insurance, we do require a deposit up front prior to being seen. So and then we require several deposit down payment type payments on MRIs and surgeries. So card on file program can be very successful. We just have chosen at this point not to require it, but that's always a popular topic of conversation within the office.
Yeah. And for I guess just looking across the board, the more you can get a patient pre-service or in clinic when they're checking in to pay prior balance, to pay a copay or a deposit, and put a card on file, the platform will automatically pick up once the claim is adjudicated, send an advance notice to the patient saying, hey, you've given us the authority, maybe up to a certain dollar amount, and after insurance has paid, here's still the balance remaining, and give them typically a week, I think in your case, right, Ben? After the advance notice is sent to the patient, they still have a week to respond to it. And if they want to change their card or have a question or want to ask for payment assistance, they have a week to kind of respond. And that has driven almost 98+% of the residual balance effectively, to use your term, become auto pay, for your practice. And it's just very remarkable to see the level of adoption, particularly in orthopedic group, where you have a pretty good spread of patients from, pediatric to folks that are 65 and above. Very, very remarkable to see. Kaylee, anything you want to add in terms of card on file and your experience with card on file?
We've just pretty much, most patients comply with it, like he said, especially 55 and under. They are more likely to actually pay if they have a card on file. They call and say, hey, why did I get a bill? Or if they get a text saying, hey, why do I owe this? And you're like, hey, well, this is this. And you go, well, you have a card on file. Do you want to pay? They'll just go ahead and take care of it right off the bat. versus the patients that necessarily don't want to put the card on file. They'll say, oh, well, I'll call back. We see more compliant patients paying at time of service, especially, or right after adjudication, and say a few weeks after, versus patients that don't put the card on file.
Yeah, thank you, Kaylee. Just to kind of zip through the next four, right? Payment options and payment plans. Ben, do you want to take this, please, and just talk about how you guys have expanded the options for the patient?
Yeah, we offer several different payment options for the patient. You can pay through our website. You can pay through text links. You can pay through email links. What we do is we send out a text to patients each week. Typically, we do it on a Wednesday. We'll send a text out with their balance due and a link to pay in that text that they can touch that link and pay very easily. We give it a couple of days, and then we send out another text. We send out a reminder that says, hey, just wanted to notify you of your balance again. And so we probably get about, anywhere from 150 to 200 payments a week that are done through text, done through clicking that link. So that's been very successful. The biggest thing, the thing that I like the most about it is that it takes away that paper statement. I don't have to mail that paper statement anymore. So tremendous value there. And I was skeptical that patients would pay through a text link, but they absolutely do. They absolutely do.
Yeah, I saw a staggering stat that as many as 32% of the patients pay within 10 or 15 minutes of receiving a text message. I wish we could even get a percentage of that through a paper statement. So just reiterates your point, Ben, about text and email certainly seem to be much more preferred by patients. The next two, I think, are talking about the patient experience and also why you were thinking about a supplement to Greenway, a marketplace partner to Greenway in terms of patient payments and the whole patient experience from scheduling to final payment. What would be some, I guess, words of wisdom from your side, Ben? You obviously had this before Health iPASS. Anything you want to kind of expand on the patient experience side?
Again, we want to make that experience for the patient as we want to simplify things as best that we can. If we've got a situation where the next time a mother has a son or daughter twist and fall and twist their ankle, and they remember how easy that experience was previously at our office, whether it be for them or their son or daughter, for maybe a parent or friend, they're much more likely to engage and not hold off and wait to make an appointment or anything like that. With staff, I like to use the analogy, a Domino's pizza analogy. So like most families with kids, we love pizza. But Domino's was never really one of our, it was never really our first choice. Not bad pizza, just wasn't the first choice. But but if you remember several years ago, they came out with an app, and they were really one of the first ones to come out with an app. It was easy to order. It was easy to pay. You could deliver and pick that up without even talking to a live person. And so it was such a convenient, easy, satisfying experience. And, the pizza was okay. It was fine. But the overall experience of getting that was nice. And so, we find ourselves now, we don't hesitate to order from them again, to use it again. And so I use that to think about the using those lessons with our own practice, make it so easy. And a lot of times the taste of the pizza, the experience with a physician maybe doesn't matter as much as we think it does. As much as the overall simplifying the overall experience of the visit.
Yeah. I hear the comment when people say we are patient-centric and we still have large waiting rooms, and the experience is from a patient's perspective, anything but patient-centric, right? Some of the digitization of the experience, meeting the patients on their schedule, letting them do things the way they want to do it, whether it's on a PC, whether it's on their phone, whether it's in the morning, whether it's in the afternoon, whether it's, hours after they get a reminder. All those things obviously are ultimately building both the convenience and the trust that is needed in a service industry that we obviously all play in. Just breezing through kind of the last topic you mentioned about payer contracts. What off late and against this backdrop of the word of recession that people are talking about, the pundits are talking about, how do you guys look at payer contracts? How often do you do it? And what additional detail you can kind of share with us, Ben?
We look at our payer contracts probably every 2 years on average. The interesting thing that I see is that, you realize that the payer, they really don't care at all about payment to the practice until that deductible is met. And so the bottom line is you've got to be good at collecting balances from your patients. You've got to be, like the slide says, you've got to be flexible in collecting those balances. You've got to offer multiple avenues, multiple ways in which they can pay. And you've really got to educate your staff. And offer multiple avenues to pay, offer payment plans, down payments, really try to zero in on what a patient visit is going to truly cost would be some advice that I would give.
Yeah, thank you, Ben. There's a bunch of questions that have come up. So in the next 10 minutes or so that we have, 9 minutes or so that we have, let me see how many I can kind of get through. Besides the questions about the specifics of the integration, here's a question that's interesting. How many billers per a busy provider do you guys recommend? So it's talking about the staffing ratio of full-time provider to a biller, Ben? What's your experience?
Let's see, we have about we have close to 24 total providers, about half physicians, half mid-levels, and we have probably about 4 billers. So what is it, about 1 to 6, I guess?
1 to 6, yeah. 1 to 6, that's interesting. And I'm going to go to this question of, we are a pediatric office and have family accounts. So when you guys think about presenting balance to a patient and collecting the balance, are you guys doing family billing, Ben, or are you looking at it from a individual patient perspective?
I think it's an individual patient perspective. So if a mother and son both have a balance with our office and it's the same cell phone number or email, my guess is they are likely getting 2
different text messages.
Text messages, yeah.
Yeah. And yeah, I mean, I think orthopedic, because it's a bit more episodic and so on, and less of a chance, I guess, that, multiple family members break their bones at any given point in time or have an open balance. It probably makes sense. But yeah, certainly family balances can be accommodated. And we have a number of pediatric practices as Health iPASS, so happy to talk more. There was a question about physical therapy, whether it's PT or OT or speech therapy. I know you guys have PT quite a bit at Carrollton Orthopedic, Ben. What do you use a different system for PT? Do you use Prime Suite? And how does all of these things we talked about function in the context of a PT visit?
I think Kaylee can probably help out here some, but we do all of our billing and collections, we do through Prime Suite still. Okay. So Health iPASS is able to extract that information. I think from a documentation standpoint, the PT visit is documented within a different maybe I think maybe WebPT or one of those separate softwares. We don't document that through Prime Suite, but we certainly bill and collect through Prime Suite for all PT visits.
Yeah, we do everything in Prime Suite except for the documentation. So all the money comes through iPASS into Prime Suite.
And from I guess the intake process or your appointment reminders, because a PT patient is likely to come in multiple times and more frequently than your typical office consult or an office procedure type of visit or an imaging visit for that matter, Kaylee, do you guys do anything different with PT visits when it comes to the process itself and the customization, if you will, of the patient experience?
I believe they still get reminders like appointments, but most of the collections happens at the office.
Gotcha.
Our front desk girl at PT collects most of our money there. Every now and then I see money come through pre-service, but most of the time it is at time of service.
Gotcha. And for I guess a orthopedic practice, right? When we think about pre-certification, Kaylee, for surgeries, for imaging, can you just maybe expand a little bit on how do you guys, I guess, look at the state of pre-certification today? What does your process look like? How many patients, as a percentage, go through a pre-cert process? Just something you can expand a little bit on pre-certs?
We probably total, just weekly, we probably see a total of, I would estimate, 500 procedures and MRIs roughly, and probably about anywhere from 50 surgeries roughly a week.
Yeah.
That's on the low
end. So
probably.
Yeah, and so what's your process for, the pre-certification with the payer on one side, as well as how does that change, I guess, how you have designed the patient experience post pre-certification in terms of their check-in process or payment process? Can you just expand a little bit on that, Kaylee, please?
So we've had to redesign multiple times because they change, of course, yearly these days. We used to, of course, be able to schedule and then say, oh, we'll get your pre-cert and get with you estimate. Now we have to get the pre-cert on the front end because 9 times out of 10, your payer dictates what your patient can and cannot have, how much it's going to cost, of course, with the high deductible plan. So we get the pre-cert, we get the estimated cost, we get with the patient, hey, your insurance is going to cover this much and let you have it, or your insurance is going to cover nothing. They're not going to let you have it, but we have this self-pay option. We have a self-pay cost for all of our procedures. Of course, surgery is a different modality and beast all in itself, but our epidurals, MRIs, things of that nature, were one of the cheaper options around for MRIs. Of course, the hospital is astronomical compared to us. And then we get the patient on the schedule, able to do that. And iPASS has made that function drastically easier on us with the cost estimator, because before we had to do it the old-fashioned way of get the deductible, get the co-insurance, figure it up ourselves, and it pretty much does all of it. We plug in the CPT code we're doing, and it auto-populates and generates the letter for us.
And the letter goes out. There is a link for the patient to make a payment.
We can download the letter or print it or send the link to the patient via email. And they can pay, gotcha, I believe, through the link, or if you send it to them, they can call the office, bring it by, however they wish to pay.
Yeah, gotcha. And, I think the other question I just saw is a question related to Intergy. There were a few questions related to that. And just like what Ben and Kaylee have shared, Health iPASS works pretty much the same, both against Prime Suite as well as Intergy. There are some specific nuances to Intergy in terms of journals and journal creation before payments can be posted. And in general, Health iPASS is complementing Greenway, both Prime Suite as well as Intergene, in terms of scheduling, reminders, check-in pre-service or in-clinic. And for those of you that have specific questions on Intergene, our client success team will set up a one-on-one conversation with you guys. And if required, I'm happy to join and address your specific questions. I want to thank Kaylee and Ben. Thank you so very much for joining us. Thank you for being an esteemed client of Health iPASS and guiding us in terms of our own growth to be able to meet your needs and make it easier for you and your patients. And many, many thanks to everybody at Greenway for their wonderful support over the years, and also in putting this together, this webinar together. Thank you again, everyone. And hopefully you've learned a lot hearing from both Kaylee and Ben. We look forward to speaking to you guys soon, and have a wonderful rest of the day and wonderful week ahead. Thanks again.
Thank you so much, everyone, for your time today. We appreciate our clients sharing their experiences and thought leadership. Please take a few minutes to complete our survey, which will pop up on our screen momentarily after the webinar ends. We will make this recording and presentation slides available to your practice via My Greenway, and you can find a copy of it under the resources section on your On24 console. And as a quick reminder, within 72 hours, you will receive your CEU credit from Health iPASS. And once again, thank you to everyone for joining today, and we'll see you soon.
Thank you again.